And if we've got a mic, yeah. Has anyone got any questions? Okay. I'll take the gentleman at the back and then Laura. Would you mind just introducing yourself?
I'm from the MGX. I'm actually partner from the global project that talked about next. But a really interesting project, and thank you. A really interesting project, and nice to see how the proof of viability, the idea, has been taken into practice. Just a question, though, from my perspective, and from a sort of scientific side of things. Given a small sample size, and I think you only tested effectively 24 patients, how confident are you that the findings really reflect the true clinical picture in the population?
Yeah, so I didn't have a chance to go into the additional QC that we did. But what the actual physiologists in North Manchester did was they got the kit and two of them separately on 10 different days, twice a day, did comparative lung function testing. So they did it on themselves, and that was really, really congruent. So when you've got a lung physiologist who knows how to do the technique properly, and they compared it directly. We then did get another 9 patients to come into North Manchester General and do same-day testing. So they were actually sat in a different room doing the remote spirometry, trying to sort of recreate the home environment. And then on the same day, they went and had the lab lung function testing on the same day. And that was all very congruent as well. So we're as confident as we can be for now. But, clearly that is something as we move forwards and we scale up. If there's any in our algorithm that we created for the kind of clinical pathway, we said, is there anything that looks a bit weird for any reason whatsoever, we either repeat it or we send them off to the lab. But the other piece of reassurance is this is a rule-out test, and they really have to have normal lung function for us to go, yeah, this is fine. So if, in terms of thinking about where its application is, if somebody's got abnormal lung function test, they're going to have it repeated anyway, and this is a kind of a rule-out test. So for that purpose, I'm really happy that this kit's fit for purpose. But as happy as I can be, but it's not an easy question to sort of fully answer.
Yeah, I think the other thing that we didn't show, and it's absolutely a valid question, is we didn't show any of the clinical and analytical validity that had been done preceding this. Now, the flaw in all of that work that preceded this is that we were essentially, however we designed those experiments, we were starting with the patient being supervised in person first. And so, we've got exposure of somewhere over 1,000 patients where the patient's been, has conducted this test first face-to-face and then done it remotely. And so we know that we've got very, very strong equivalence there. The challenge is, can you transfer that into an environment where the patient's spirometry naive? And so that's the kind of delta that we're trying to address. And so we definitely need to continue to monitor it in the next phase. We've also talked about the fact that I'm not sure everybody was English speaking as the first language. I don't think they were, but we didn't have the translations into local language. And again, that's something that we'd need to test as we expanded that out. So there's a whole set of sort of next steps, but really high confidence that the underlying technology and training is sound. It's the application into naive patients that was the challenge.
Okay, thank you. Laura?
Brilliant example, isn't it? I loved your height, plateau scale and height example, because that is sort of those little nuggets of real world that, in a clinical trial that industry take for granted. You've got a whole team there doing clinical trial for patients in a really controlled manner, and, it's so easy to not realise, we've had it recently on an obesity project we're working on, where people don't know how much they weigh, and if they do, they often don't ring up the GP and say, by the way, my weight's changed in the last few years. So what is recorded and what assumed, it is so different in the real world. So obviously, I said in my sort of opening remarks, we don't like to be defeated. And we can't help but think there's still got such untapped potential. And it's whether or not, what direction would that take? Does it warrant a further research piece, an actual, real world evidence study? Or where do you think it's best to place it in the pathway for now, pending anything else that may happen in the future? Because I think Matt's right, the technology will keep evolving in this space, won't it? And what we don't really want to do is take our foot off the gas, wait for new technologies, and then kind of have to start again, if you like. I'm sure the kit will become better in the future with the use of AI. So, you do think, because of the data we've got in GM now, we would be able to work with providers to identify the cohorts who this could be good for and start to do proactive outreach to them, not asking clinicians to tack that on top of the day jobs, So there's a whole big swim of it's got so much potential running through my mind. I just wonder kind of what may or may not happen next. Or is this, it's the end of the line for the HIA, but are there any opportunities for what next?
Well, I did a lot of exploratory work with the CDC, Laura, and they were absolutely desperate for us to go in and work with them, because besides the COPD, they've also got the breathlessness pathway and other pathways, and they actually couldn't deliver them because of their waiting lists. And we would have been able to rule out at least 50%. And you've already said the technology's already changed. The test is easier. It's a third of the cost now, the new technology. And what we said is there's no training required. You actually, with the new technology, wouldn't even need coaching because it's that simple. So it could sit in a patient's home, it could sit in a GP practice in a room, and a patient could go in and do it there. A healthcare support worker could support delivery. So I think I would target the CDCs first because they have got biggest waiting lists. And as Binny said, you've got very sick patients and they're not being triaged, so you want to move those lists quickly at the moment.
I think there's something in medicine where sometimes we go, it's an absolute dog's dinner, we know that, right? But rather than put in something that isn't absolutely perfect, because there isn't 10 randomised controlled trials showing it's perfect, we'll just do nothing instead. Yeah. So it's kind of, is it good enough to rule out a load of normal lung function? Yes. I think we've shown that in our small cohorts. Will that take pressure off an overloaded system? Yes. Possibly by 50%. Will it make sure our resources, our precious secondary care resources, are used more appropriately? Yes. So, yes, it might not be absolutely perfect, but I think it's good enough to apply in that setting and really be a win for the system. I think it'd pay for itself very quickly in terms of getting the right people, the right help into pathways, keeping them at hospital. And those are the kind of things, what's the value for the system we have to think about, but that's where I think it sits.
I'll just add a point to that, that we know in Greater Manchester 40% of emergency admissions with respiratory illness aren't on a disease register within general practice, so they're either not on an asthma or COPD register, and part of that is because they've not had the diagnostic. So we've got groups of people not diagnosed, probably not on the right therapy, who are continuously having emergency admissions, particularly over the winter. So again, anything that we can do to reduce the numbers that need more formal face-to-face diagnosis is just a kind of win-win all round. Okay, thanks. There was a hand at the back.
Morning, Louise. My question is, how are these points reach marginalised communities, for example, the kids who are in trouble community? They already have massive barriers to access to healthcare. And did you have really, really high rates of issues with the health?
I'll be really honest, that is, we were looking at underserved groups. So initially it was patients with language barriers, difficulties, sight and hearing, and we haven't looked at travellers at all, I'll be really honest. It's not even something important to focus in POV1. It would probably be something that we'd eventually explore in POV2, but I have heard that mentioned before, actually. So
it's really challenging with that community because a lot of them don't have a fixed address, and trying to get, trying to sort of understand how, I think we'd have to do focus groups with groups of travellers, because I've not got the first clue about the life that those guys lead, how they manage to access healthcare as it is. Yeah, and I think that's one marginalised community out of many marginalised communities across Greater Manchester. It's such a massive problem with all the different underserved communities that is going to need.
I can tell you some of the work that Health Innovation Manchester have done with our Kittinis, our PPI, that she has gone out into food banks and other places like that. And with the new technology we've got, or what's coming online, what we can see, you actually could, if you could just have a small room at the side, could potentially do these sort of tests in those sort of places. This is no risk to anybody who's been testing with the way the tests are done. Sit in a pharmacy. I mean, it's so mobile and so easy to tune to what's coming out and what the new technology looks like. It would be very, very accessible.
Okay, thanks.
Hi, I'm Nancy. I'm one of the programme managers at Health Innovation Manchester. Just sort of on the same theme. We did some work a couple of years ago around reaching communities to get COVID vaccination. Worked someone died. And what we found really valuable was working with public health. And we felt that they very much worked with community leaders, definitely the Jewish community, the Yemeni community. And that was the only way that we could cross those cultural barriers. I'm just thinking maybe, got lessons from that.
Yes.
We've just pushed that really. But I think through public health as well, they did manage to reach out to Romani travellers. Because it's about getting those links that are trustworthy. Because a lot of people don't trust physicians. They don't trust people that are not part of their religion or culture. Right now.
Thanks, Andrew. Any other questions?
Director's innovation manager. I think in great tech and great to offer patient preference at home, etc., looking at that path, I wasn't sure if somebody's got reduced lung function, if they then get fast tracked or they just get added to the waiting list.
We haven't got that far down with that. I think the proof of value 2 would really be around, can we scale it up? And then it would really think about how do you then integrate this into business as usual. But I think the idea would be if you reduce waiting lists by 50%, then the people who really need to be in secondary care. We did actually create a bit of a pathway for the community diagnostic hubs to say, there's a triage at that point of entry where somebody would clinically look at it and go, right, fast tracks. People often do get fast tracked anyway if there's a suspicion of lung cancer. That's a completely different pathway. But actually, no, we won't do a remote spirometry on this patient because it sounds like they're too sick and they should go straight into. So I think there are ways in which you can do that, but we didn't get as far as redesigning those pathways or how you really integrate those, because we've got to do proof of value 2 first.
Thanks. Any other questions? Oh.
It's Birchall from the University of Manchester. I just wondered if there'd been any clear findings yet as to the economic feasibility of something like this. Did you look into, obviously, the cost of the kit, the support calls, the SINs versus what could potentially be projected savings from reducing that waiting list?
So that, yeah, there was some work done in the background, but again, because it was such a small study, it's a bit hard to say. And again, with technology moving forward, we knew the cost of the equipment we were using and what that would involve for that small PME1. But with the new technology, we know it's more cost effective and will require probably no ARTP physiologists, which again would cause a cost reduction with AI interpretation. So I can't really give you any sort of figures and answers to that because it was such a small study on it. So.
I think putting some of this into context, the inhaler budget for Greater Manchester is something like £87 million. And if you think maybe a third of that is inappropriately prescribed, right? So that, it's huge. And then you think about the hospital admissions for people who are undiagnosed and into hospital, that's, again, probably tens of millions of pounds. So even if we saved a tiny percentage of that, I think it becomes very cost effective. But I don't know if you've got any.
Yeah, I mean, we've done quite a lot with it, and you're hitting on the main point. So, on the cost side, never mind patient impact, which is clearly the biggest impact. But Paul has already said 40% of emergency admissions are people who haven't been diagnosed. You can do some analysis in terms of trying to project how many of those are preventable if you've actually got people on the right treatment, and it ends up being quite a big number, actually, doesn't it? So that's kind of one area, and then the drug budget, and then there's the readmission impact of people then who aren't on the right treatment, and there's potential to use this technology as well as part of the discharge pack in follow-up. So there's a whole different set of economic benefits. Cost side is the technology, which is coming down. I still have a slightly different opinion to you in terms of whether you do need the physiologist, because you get really good FEV data. You don't get FVC in the same way without a physiologist, and that needs a bit more. So, but again, that depends on the patient population, doesn't it? So I don't fully disagree with the either. I think there's a triage element there. And then the point about, does this need to be at home, or does it need to be in a setting that the individual will access? Because actually the biggest cost is the logistics. It's sending the device out, it's getting it back, it's cleaning it down, it's sending it back out again. So actually, if you're going into a pharmacy, as you said, Laura, or community centres or wherever that, even temples and mosques or wherever that you can do these things, that changes the cost side of the equation markedly. So I think these are the things that we need to figure out next to really drive the impact.
We've already got massive lung health screening programme in Greater Manchester, so there's people having CT scanners in the back of lorries, and you could just tag this on. A lot of those are finding people with undiagnosed lung disease. They could also have a remote spirometry while they're there. That's taking pressure off primary care. It's putting people into diagnostic pathways. So, it's about not reinventing the wheel, thinking differently about where you put this technology. Can you put it in the heart of communities so people can access it? So I think it's not a scope.
Yeah, I think you can see we've got more questions than we have answers. You start peeling the layers of the onion, and you're thinking about, because we did do some work about the people who were slightly nervous with technology in their own home on their own. Could they go where another healthcare person would be there if they needed? So we explored that in health centres and other community areas, and would they have a cupboard where we could keep kit, and what was the kind of return process? And I think, to your point, Vicky, if or when we get to the stage that we've got some technology that's more mobile and can be used with people in the communities, the whole commissioning of that would have that full health economic benefit, not just the cost of that diagnostic versus the other, but all the wider benefits around prescribing, hospital admissions, etc. We've got a question right at the back. Sam's running up down there. There's Mike. Thanks. Just introduce yourself to us, please.
Hiya. I'm from the University of Salford. I'm sort of working on respiratory devices. Sorry, I missed a large proportion of the presentation to travel issues. I was just curious what you thought of the long-term sort of sustainability of spirometry when Asper and Lung have just invested a lot of money into auditory and visual AI diagnostics for respiratory.
So I invest a lot of time and effort into looking at audio and visuals, and whether it's true audio, whether it's cough, whether it's other kind of listening to breathing. At the moment, they're a below average rule out test, and they're certainly not a differential diagnostic test. You would hope that they would improve, absolutely. So that's kind of one horizon that's definitely coming. I think the step before we get there is more likely to be oscillometry, where you can get the data without needing to have such kind of high lung volume, and then that will remove, I think, a lot of the need for the physiologist. At least for the majority of cases, you're still going to need them for the complex cases. So I think this is yes, there's an end goal in sight, which is not spirometry. To be slightly philosophical, though, and I deal with this across a load of different conditions. If you're saying to a clinical community, take this massive leap to something completely new, that's a lot harder than saying, take a step to something that's easier and then take another step and take another step. And there's the change management elements of, what we've gone through here is, you talk to an awful lot of consultant, respiratory consultants. The gold standard is in their office, in front of them, with spirometry, with reversibility. That's the gold standard. There's a step to being able to say, okay, can that be done in a different location then? There's then a step that says, can this be done with another technology, but actually you're still breathing into a device and measuring things? And then there's can we pick this up from the environment around the citizen and see what's going on with them? And I think we just need to kind of walk people along those steps with the evidence. Maybe I'm not ambitious enough, but I'm trying to kind of think about the change management that goes with it, not just the technology, but, you can do the real job. So
I mean, I think I don't think it's going anywhere for the time being. Let's say that, but I'd be delighted if spirometry became just a small part of the diagnostic pathway, just in people who absolutely need it. It's actually really hard to do. Our patients hate doing it because actually you're knackered afterwards, even if you haven't got lung disease. Yeah. It's a tough test, and you have to do repeated measurements, and actually be really great if we could phase it out some way. But I think it will end up being part of a suite of diagnostic tests where the most appropriate people are channeled into that. And with the amount of respiratory disease we have, that's not going to be a small number. So, but if we could confine it to secondary care lung function labs, brilliant. That would be a win. But it just blows most clinicians' minds thinking about moving away from spirometry right now. Like Matt said, it's got to be phased.